In the radiation oncology department at Rochester General Hospital, oncologists report that on average, approximately a third of new patient visits with breast and prostate cancer patients are interrupted due to lack of information that should be given by the nurses. This has been an ongoing issue since before I arrived to the clinic. It's an issue that needs to be addressed because it's important for providers to build a rapport, perform thorough assessments, and provide all information to patients to offer them the best treatment options. For patients, it's important to have confidence in the staff caring for them during such a stressful time, and they need to be allowed to make the best decisions for their treatment. The team was comprised of 3 radiation oncologists, our clinical nurse leader, my preceptor, and 2 other radiation oncology nurses. All nurses were given the opportunity to participate after the project was explained, but one declined. The purpose of this project was to reduce the interruptions and delays in new patient visits caused by missing information. Most of the time, not giving the providers all the information they need is completely preventable, and it impacts both the provider process and patient experience. After a lot of research, the simplest, most effective, and most cost-effective way I decided to do this was to implement checklists. After collaborating with the team, we decided on goals. During phase 1 of the project, more information will be required for only a fifth of new patient visits. By phase 2, more information will be required for only an eighth of new patient visits. Providers agreed that this would be both very beneficial to the practice and our goals were reasonable and achievable. Management has been very focused on the budget lately, so the change had to be done in the most cost-effective way possible, or management wouldn't support it. When information is missing from the visits, it makes more work for the providers and the nurses. It can make us look unorganized and unprofessional to patients who are going through possibly the most difficult part of their lives. In such a high-stress situation, if patients aren't confident in who's caring for them, they may not be willing to let us treat them. If our providers can't present them with all the necessary information, the provider can't offer the most appropriate treatment, and the patients may not be able to make the best decision for themselves. Breast and prostate cancer were chosen because the workup and treatment courses are relatively straightforward. The nurses who chose to participate were given a chart to keep track of each time a provider asked for missing information during their visit with a new patient. They were also supposed to record the total number of new patient visits with breast and prostate cancer that they prepared the charts for. Since an exact number of times providers were missing information was unable to be obtained before the study started, nurses and providers were asked to give an estimate of how often they require more information for a baseline. The checklists were typed, highlighted, and placed in high visibility areas near the computers. Suggestion folders were opened at both locations, and patients were also interviewed to determine whether providers had to look up information on the computers in the rooms during their visit and to get their opinions on how smoothly their visits went. The checklists were introduced on February 20th. Data was collected starting February 27th, and it was evaluated on March 27th, then evaluated again on April 27th. Discussions took place throughout the course of the study, and after the first evaluation on March 27th, it was determined that there was one piece missing from the checklist that providers were beginning to ask for. There are relatively new tests being done for breast and prostate cancer that nurses need to get the results of to ensure the providers offer the most appropriate and beneficial treatments. The goals were exceeded as information was missing a quarter of the time when the goal was a fifth of the time at 4 weeks and a tenth of the time with a goal of an eighth of the time at the 8-week mark. However, the results may not be an accurate representation of the study's success. The study did not have an exact measurement as a starting point. It was based on a provider estimation. During the first part of the project, the clinic started assigning nurses specifically to providers. This was a problem, as the one nurse who chose not to participate in the study was assigned to a provider who sees a lot of new patients with breast and prostate cancer, so it's probable that there's actually data missing that would have impacted the outcome. A new provider was hired, and we have had a nurse assigned to her even when she was only seeing one new patient every couple days. And if it was a nurse who was participating in the study, she was missing the opportunity to record data. Since the study was such a success, we've started making checklists for just about everything in the clinic, including all types of cancers. For example, our head and neck patients require a lot of work in terms of getting them set up for a dentistry appointment, possibly a G-tube insertion, etc. It's difficult to remember everything that has to be done, so we've made a checklist. We're also starting to see more special procedures for cervical and brain cancers that require anesthesia, neurosurgery involvement, and several other disciplines, so I've made checklists for those as well. The success of this has been discussed with management, and when we hire a new nurse in less than 2 years, introducing the checklist will be part of orientation for them. The study was chosen because it addresses an ongoing and significant issue, and it's also very cost effective, so it's backed by management. I think this has helped to show everyone that there are simple solutions to the issues we may have if you do enough research and can properly execute the change. The clinic runs more smoothly and efficiently now, not only in terms of new patient visits, but also with procedures that some of us are not too familiar with because not all of us have a surgical or procedural nurse background. One positive change that I didn't consider when starting this project is that providers don't get behind in their visits as quickly now because they're not coming out of the room and asking for information, which delays their visits. Patients are confident in our ability to treat them, and I believe this project has improved patient satisfaction as well as provider satisfaction.